Okay, I'm going to record this session so that we can share this out with our LyfeMD users and wider audience afterwards for future purposes as well. I'd like to just start by welcoming our co-founders, Dr. Lorian Taylor and Dr. Maitreyi Raman, who are going to be taking us through the session today. It will look a little bit like some of the previous sessions and a little different in the sense that Dr. Maitreyi Raman and Dr. Lorian Taylor will be having a little bit more of a conversational aspect to this, as well as the questions that you have all sent in will be presented later on. Okay, so what I would like to do is jump right in, if that's okay. And Dr. Raman, if this is, I'm going to now hand over to Dr. Taylor to sort of be discussing, and you can start the conversation backwards and forwards as it flows naturally. And if anybody has got any questions, bit of the housekeeping, please put them into the chat, and we'll try and bring it up if it's the right timing for that particular slide or segment of information. Otherwise, I'll save the questions and we'll see if we can get to them at the end of the session. What we've also done in the past for people who've submitted questions through the session is we've responded to them individually afterwards. So we'll try to get to you, and please do feel free to ask questions and join in. I do have a slide, a poll that I would like to ask people to begin with, that I am just going to put on your and
actual link I pasted on the chat box here. If you want.
Sorry, I'm not sure I could hear somebody talking just then. I'm sorry, I heard something and then I've just lost what's happened there.
Charlie, should I get started maybe with our first question, or did you want to start with the poll?
The poll's disappeared from being opened in here from the saved one from earlier. So maybe I can put, yeah.
Sure, I'll just get started. So Dr. Raman, I'm wondering if you can tell us a bit more, how do people get diagnosed with IBS? And then what should their first step be after they receive a diagnosis? Do they have to see a GI to get a diagnosis?
Okay, thank you, Dr. Taylor, for that question. So IBS, what can I tell you about it? It is a very common condition. It can affect anywhere between 12 to 20% of the population. So 1 in 5 people may expect to have symptoms of IBS. And IBS, typical symptoms that accompany a diagnosis of IBS are abdominal cramping and or bloating that improves after you pass gas or after you have a bowel movement. And when this is associated with constipation or diarrhea or even both, these are all symptoms that are compatible with a diagnosis of IBS. Now, you can make a diagnosis of IBS even if you don't have a colonoscopy or even if you've not had other tests like an ultrasound, for example. However, typically we would recommend that you have some basic blood tests and evaluate for celiac disease, which certainly can mimic symptoms of IBS. And if you have a family history of colon cancer, or if you have any other symptoms beyond what I've described, like nausea or vomiting or blood in the bowel movements, in those circumstances, you need additional diagnosis or additional testing, like a colonoscopy, for example. So the short answer is, yeah, you can make a diagnosis of IBS even without seeing a gastroenterologist, but a GI is needed if you have atypical features or if you have new symptoms beyond the age of 50.
Okay, so if the symptoms change over time, that's when I should probably go back and talk to my family doctor about that for sure.
Absolutely.
Okay, that's great to know. So you get diagnosed with IBS. What's next?
Okay, so then we start thinking about treatments. Now, when we think about IBS compared to other medical treatments, oftentimes the main symptoms or the main treatment options are directed towards symptoms rather than the cause of the disease. So that's why many people with IBS may be left a little bit unsatisfied with their results with their medical management, because we're putting Band-Aids on treatments. When you present with constipation, we're giving you anti-constipating or laxative therapies. When you present with diarrhea, we are then treating diarrhea using anti-diarrheal medical therapies, but we're not treating the root cause. So important to having success and durable response with IBS management requires both treatments that address both the cause of the illness as well as the consequence or the treatments or the symptoms of the illness.
Okay, so that's really interesting to me. So what is the cause? Is really when people are diagnosed with IBS, is their intestine different? What is causing all that pain and bloating and constipation? What makes it different? What causes that?
Yeah, great question. And so if it was as simple as that, I think we would not really be left with any burden of IBS in our patient practice. But unfortunately, this really reflects a lack of true understanding of the contributing factors that contribute to IBS onset. But in 2023, this is what we know. We know that the brain and the gut are intimately connected, and that your thoughts and your feelings and your emotions and the way that you feel intimately influences how the brain functions or how the gut functions.
Okay.
So this brain-gut connection, otherwise known as the brain-gut axis, is really very much responsible for either contributing to an altered motility of the bowel or contributing to the other symptoms that we've described. Fundamentally, your bowel is perfectly normal. If I were to take the intestine, either the small intestine or the large intestine of someone with IBS, and put it under a microscope, it would be pristine. In contrast to someone with Crohn's, whereby their bowel would have some ulcers, it would be swollen, it would be red. So you cannot.
That's really interesting. Yeah, I'm wondering. Oh, sorry. Go ahead.
You can't distinguish a normal bowel from an IBS bowel.
Okay, so Mary, I just see there that you have a question about this. Do you want to share your question? Or no, did you do that by accident?
I have a question.
Okay, thanks, Terry. Yeah, go ahead.
Thank you. Actually, talking about the medication, like I've been diagnosed with ulcerative colitis like 15 years ago, and it was mild, and we use 5-ASA, and it worked fine. 2 years ago, became severe. Then I went to Biomed. I used Entyvio, Remicade, and Rinvoq, and all of them worked for a short while and stopped. Seems my body is fighting the medication instead of fighting the disease itself. Like, is this normal, or why my body is fighting the introduced medication? Because the medication did, like Rinvoq, worked marvelously for 7-8 weeks. Right now, I'm off of it. Like, I'm really walking to a wall. Like, is this normal? Is it? I don't know. Do you have any idea?
Right. So, Terry, I can't necessarily provide specific medical advice to you, but generally speaking, so now you have a diagnosis of ulcerative colitis, which is different than what we're talking about, because we're talking about irritable bowel syndrome.
I lost you.
Sorry, can you hear me?
I can hear you now, yeah.
Okay, sorry about that.
Okay.
I don't know what happened, but what I was saying was that you have ulcerative colitis, which is different than IBS, but ulcerative colitis is definitely challenging to manage because we still have not yet found the cure. So when we look at treatment options for ulcerative colitis or Crohn's disease, we typically are reliant on medications called biologics. And examples of those biologics are exactly the ones that you mentioned, and they work by influencing or blocking the immune system response. But unfortunately, what you're describing is very, very common, where people may respond inadequately to many of the biologic therapies. And this is exactly why we have developed our research program to understand the underlying influences of inflammation in the gut that leads to ulcerative colitis. And until recently, really, there was not much interest or bandwidth or funding to support inquiry into dietary interventions and understanding how diet influences the immune system and how diet influences the bacteria that live in the gut. So listening to your history and listening how you've not responded to the usual biologic medications leads me to wonder whether you might have a better response if you start thinking about integrating some novel therapies like diet and microbiome therapies into your overall disease management. So yeah, unfortunately, your situation is a little bit too common, and we do need to find a solution for you that results in a durable response.
Great. Hopefully. Thank you.
You're
And
welcome.
that really leads me to a thought, Dr. Raman, is can people with ulcerative colitis and Crohn's disease also have irritable bowel syndrome? And could some of the symptoms be affected by what they're eating?
Yeah, that's another great question, Lorian. Thank you. So now, going back to Terry's question about how he's been changed onto multiple medications, if that indeed has happened, to me, that would reflect that he probably does not have underlying IBS and that he has active inflammation to which his gut has not responded to the usual medications. But to your question, absolutely, 30% of people that have Crohn's disease or ulcerative colitis can also have IBS superimposed on top of that. Now, how you would know what is leading to what would totally be dependent upon your colonoscopy results. So if you have ulcerative colitis and you still have bloating and cramping and diarrhea, a colonoscopy would let us know whether you have active inflammation, in which case we have to push the medications and go down the medication route. But if your colonoscopy was normal, we would then conclude that this is not a flare of your colitis, but maybe more a flare of IBS, which would then warrant dietary interventions and other IBS interventions.
Okay, so how could an eating program help people with IBS? Does it take care of the symptoms?
Absolutely. So in fact, when we look at most of the guidelines in North America, as well as the European guidelines, dietary management of IBS is front and center. Now, the dietary managements range from usual good practice, healthy eating practices, all the way to specific formal diets. So depending upon your symptoms and the severity of your symptoms, we would either recommend a good sort of basic eating hygiene program that's associated with IBS improvement in symptoms, all the way to an elimination diet.
Okay, so how would someone go about implementing a diet? There's so much on the internet about what makes a difference. What would you recommend?
I would say the most frequently researched diets for an individual with IBS would be the low FODMAPs diet. Now, FODMAPs is basically an acronym whereby each of the letters stands for something. And so the FODMAPs, if I can spell it out for people, it really stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So that's a mouthful, I understand, but basically all these components are different types of sugars and different types of carbohydrates that you would consume in your diet. And when you have a bacterial profile in your gut that is incapable of metabolizing or digesting these carbohydrates, you're left with a lot of bloating, gas, diarrhea, and constipation. So if we can eliminate these foods from your diet, or at least reduce the frequency, that can improve a lot of symptoms very, very quickly.
Okay, and now you did mention, you were talking a bit more about the gut-brain axis. And I'm wondering about yoga, meditation, and those types of therapies. How do these help with IBS? Do you have to do both? Do you need eating and these therapies for a truly good program to actually work? How does it work?
Okay, so what I typically do when someone comes to me with a diagnosis of IBS, I will refer them to a dietitian that's familiar with IBS. Not all dietitians are familiar with IBS, so it's important to make sure or to be referred to a dietitian that's knowledgeable, first of all. And the dietitian is an excellent place to start because...
Oh, Dr. Raman, you just went on mute again.
I'm sorry about that. That happened spontaneously. I'm not sure why that is the case. But what I was saying was the dietitian is definitely the first place to start. And what they can do that I or any other GI doctor will not be able to do in the clinic is get a better assessment of what you are eating. And after the dietitian reviews your dietary intake and the foods that you consume on a regular basis, they will quickly be able to identify if you're eating foods higher in these FODMAP items. And then if your diet is high in these FODMAP items, they will counsel you on how to eliminate or decrease the intake of these foods and increase intake of other types of foods that are lower in FODMAPs. So if you have a high FODMAP food diet or high FODMAP diet, then a low FODMAP diet is definitely the place to start. But some of you might be thinking, well, I've already been on the internet. I've read about this. My diet's nice and clean. I'm not eating extra sugars. I'm not eating too much wheat. I've eliminated milk from my diet. I think I'm already following a low FODMAP diet, but still I have cramping and diarrhea and I'm not feeling well. And if that's and by the time a patient comes to see me in my clinic, they've been waiting a long time. So patients are already very knowledgeable about what works and what might not work for them. So in that situation, I already expect people have tried different diets to manage their IBS before they come and see me. And once I do see them, then I try and get a better understanding of how the brain-gut axis might be contributing to their symptoms. So I'll do a bit more of a deeper dive. I'll try and understand about their stress levels, about any anxiety, about examples of mental health that might be not optimized. Is there an element of depression? Are they just taking on too much? Do they have too many responsibilities? Do they have a component of anger or fear? Or is there change in their daily lives? And I bring that up because there have been such nice studies that have shown that having anxiety or stress can either cause the brain to expand, we call that hypertrophy, or shrink, or atrophy.
Okay.
And the brain has multiple different areas or lobes or components that guide the connections between the brain and the gut. So for example, if there's a component of fear or anxiety, then your brain may expand in a way that's not favorable, and it may liberate a bunch of chemicals or signals to the gut that can alter the signaling pattern. So when we think about yoga, and I don't mean exercises or postures or any of the typical things when we think about yoga, but I think about those, but I think about breathing because breath work is so critical to improving the brain-gut connection. And I think about mindfulness practices. And these have really been shown to modulate the brain in a way that can improve the motility of the bowel and improve symptoms.
So do they do that? You mentioned that for the brain might have hypertrophy. So do these types of therapies actually fix that? Is that why they are effective?
Yeah. So in fact, and I usually have a beautiful slide that I share, although I don't have that today, but there are many different ways yoga and breathing and mindfulness can impact that connection. So it can cause the brain to remold. The brain's very plastic. We call this concept neuroplasticity. Your brain on any one day doesn't look the same as it does the next day. And that's because it's so influenced by your feelings, your emotions, and your thoughts. And so on days we feel really good and we have no anxiety or minimal stress, the brain is in its optimal condition. And on days when we don't feel our best, it doesn't look the same way. So being mindful and living in the present moment and engaging in practices that enable that then facilitate the motility of the gut in a way that's normal. You can decrease the flight or fight response, and also all of the hormones or the chemicals that can really enhance, feel, or worsen these symptomatic outcomes.
Wow, that's so interesting. I didn't realize that the brain changed so frequently and was so affected by the way that you're feeling too in a day. And what about exercise? Can exercise help as well?
Absolutely. And so exercise, and this is the beauty of IBS, that treatment as I think of it, there are really different strokes for different folks. So depending on what you like to do and how you want to manage your stress and your emotions and your anxiety, yoga and breathing and mindfulness, absolutely, very, very effective. But some people find it hard to know where to start and and hard to know what the practical tools are. Same for exercise. Now, exercise works in a slightly different way. Exercise improves what we call endorphins, or these positive neurochemicals from the brain, and it leaves you with a little bit of a feeling of a high, if you will. And those feel-good neurochemicals can overcome pain. These are all analgesics. In fact, exercise may be even more powerful than Tylenol or Advil to manage various types of pain-related symptoms. So exercise absolutely is a good place to start. But with GI conditions, I always caution my patients that you have to go slow, especially if you've not been exposed to an exercise program. And it's best to do it with guidance, because when you have abdominal pain or diarrhea, the effect of exercise is a little bit unknown. So starting slowly and building up over time is absolutely the way to success with an exercise program.
Okay, and now what about if someone has a reflux disease or dyspepsia, an upset stomach? Will these therapies help them as well?
Okay, so now these symptoms that you're describing are a little bit outside of the domain of IBS, but having said that, they often frequently travel together. So
Okay.
someone with IBS may also have acid reflux, or GERD as we call it, or they may have dyspepsia, or otherwise known as indigestion. Now, so if you are experiencing these symptoms, I would also recommend that you do need investigations depending on where you are in your journey. So if you are 25 years of age and you've got acid reflux and you've got some nausea and indigestion and bloating, you may not need other investigations. You can try all of these interventions that we're just discussing now, the diet, the mindfulness, as well as the physical activity. And weight management, of course, is really critical to help with all of these symptoms. But if you're 55 years of age and you have these symptoms, before you embark on this program that I've just described, I would say that you do need an endoscopy, an upper endoscopy, whereby we look inside of your stomach and we make sure there aren't other factors that are driving these symptoms. And these other factors commonly would be stomach ulcers, duodenal ulcers, esophageal ulcers, strictures or blockages in the gut. And these things we would need to rule out before I would be confident on recommending this approach.
Okay, that's great to know. So for younger people, really, they may not need an endoscopy, but for people over the age of 50, typically the recommendation would be then to make sure that there's nothing else present that's causing these symptoms.
Absolutely, that's a great summary. And the only thing I would add to that is that even younger people still may require investigations if there are other alarm features. So none of these conditions should result in unexpected weight loss. So if you have had unexpected weight loss, that would be a red flag in my mind. And if you have a family history of stomach cancer, colon cancer, Crohn's disease, pancreatic involvement. So if there's a family member that's had any of these things, in that case, I would also choose to expedite investigations.
Okay, thanks. I just want to jump back to the exercise. I have one more question there. So I've been asked this quite a few times by patients, is often with IBS, sometimes there may be some depression, anxiety present, and that can often result in feeling very, very low energy and fatigued. So if people are feeling fatigued and they start, even just doing something gentle and they still feel fatigued, how do you feel should they continue? Should they work through that fatigue? Should they just start slow. You did mention start slow and work up. I think that still makes sense. But, lots of times people are told if you feel fatigued, don't exercise. So I'm just wondering about that.
Fatigue, unfortunately, is a very old, very common symptom that many people face. It's more commonly observed in Crohn's disease or ulcerative colitis compared to IBS, but undoubtedly it can be seen in IBS as well. So how I respond to fatigue is determined by their underlying conditions. So if one has fatigue and they have IBS, I fully agree with what you're saying, Lorian, that I would encourage them to start slow and to gently push through it, and then listen to their body, and then try and push the boundaries a little bit, whether if you walk 1 kilometer today and you try for 1.5 kilometers the next day, or you try, jogging for 5 minutes today and then you try it for 10 minutes the next day. I would fully support that for an IBS patient. But for someone that has Crohn's disease or colitis, and if they're seeing blood in their stool or they're having diarrhea or they can't make it to the bathroom on time, in that situation, if they try a little bit of exercise and their symptoms are getting worse, I would tell them that they have to scale back a little bit until their symptoms are better managed.
Okay, thanks for that. So I want to move on now to we talked about mind-body interventions and yoga. I mean, there's been a lot in the literature as well as in the news around cognitive behavior therapy. How do you think that can help patients or people who have IBS or GERD or dyspepsia?
Okay, and I'm sorry about this, but can I just make one more comment about the fatigue? I'm really curious, even just within this audience, you don't have to answer, of course, if you're not comfortable with it. But one thing that's becoming more and more noted in the literature and gaining more awareness is around the quality of one's sleep. So not just the quantity of sleep, but also the quality of your sleep. And sleep disturbances are now very commonly being recognized as a contributing cause for both IBS as well as fatigue. So it's not something that we talked about or I talked about in any detail today so far, but certainly engaging in any of these practices will enhance your sleep quality. And by improving your sleep quality, one may also expect their fatigue to improve simultaneously.
Okay.
So coming to your question around cognitive behavioral therapy, you know what? I may actually turn the question over to you, Lorian, since you are an expert in this field.
Well, I was the one asking the questions here.
So maybe we can have a tag team approach here, and I can just start by saying that in IBS, there has been a lot of medical literature to support the effectiveness of cognitive behavioral therapy. So why don't you explain, Lorian, what does CBT mean to you? And then I will then follow that up and tell you about how the data look in IBS specifically.
Sure, thanks. So when I think of cognitive behavior therapy, it might also be called CBT. We call it at LyfeMD, retrain your brain. What this has to do with is really looking at how you think. And it's almost like a training program for your brain. So it's almost like exercise for your brain so that you can take thoughts that are disturbing you, that are causing you distress, that are making you depressed, or you have these emotions that you can't explain. You don't know why they're feeling them. You don't know why they're so strong. And you can actually teach yourself to deal with those emotions in a very healthy way. It's not about not feeling things, but it's about how you process those feelings and how much they affect you. Because in cognitive behavior therapy, what it really does is the theory is that the way you think affects your body and how you feel. It affects your emotions and how you feel. And it also affects your physical reactions, like things that happen in IBS. And you can actually change some of those things just by changing your thoughts and dealing with emotions in a healthy way.
Okay, that is excellent, Lorian. I love that explanation. And so if I can follow that up and tell you that very recently there was a very nice study that was done whereby they took people that have IBS and they did something called a functional MRI. So all of you would be familiar with what an MRI is, but a functional MRI is something slightly different. So not only do they look at the actual structure of your brain, they also look at how each part of your brain talks to each other. How does your frontal lobe talk to your parietal lobe? How does it talk to the cerebellar lobe? All different components of your brain. And what they found is that they have the brains of connectivity. We call these connectomes. The connectivity between these various brain components in people with IBS is fairly similar. But after they undergo a cognitive behavioral therapy program, the connectivity is completely different. It changes tremendously. So that supports your comments, Lorian, about why you can feel better after you undergo a retrain your brain program. It's because you're retraining those neurons in your brain to be able to talk to each other in different ways. So we didn't actually, people reported feeling better, but we never understood why before. But now we understand the why. We understand that the neurons talk to each other in different ways as you start to retrain your brain. So in IBS, there's lots of literature. There have been more than 30 studies that have confirmed that a CBT program is very powerful to improve your symptoms. So after diet, in fact, CBT is a strong recommendation by various professional organizations to support a patient with IBS.
Okay, thanks for that. I just want to move on now to some of the questions that we got from patients, because I want to make sure, and listeners today, I just want to make sure those get answered. So the first one is, why do I have a lot of stomach noise and rumbling and pass a lot of loud gas? These are all new symptoms. What can I do about it?
Okay, well, if these are new symptoms, then I would have a bit more concern than I would if you had told me this has been going on for 5 or 10 years. So depending on the context, depending on your age and your family history and other symptoms, you may require some investigations. So if that's the case, you should talk to your family doctor about getting a referral to a gastroenterologist. And prior to that, you would need to have either an ultrasound or a CAT scan of your abdomen to make sure we're not dealing with other pathology like colon cancer, like stomach ulcers that may also contribute to these symptoms. Now, having said that, having stomach noise and rumbling and gas is very, very, very common. And it's very natural to pass gas more than 50 times a day. So that's kind of what I tell my students who always ask about these types of questions. Passing gas is normal, and you can pass up to 3 liters of gas per day. But the only thing that bothers me here is that these are new. So if new symptoms, think about, have you changed your diet? Have you been traveling recently? Is somebody in the household ill? Have there been infections recently? All of these things can influence this. But if the answer is no to all of these things, then further investigation is needed.
Okay, yeah, as a dietitian, the first thing that occurred to me there is about beans, the musical fruit. So sometimes I think diet can also affect some of those symptoms for sure. So in terms, I think we've answered the second question about therapies that are available for the brain-gut connection. We talked about a lot, not just yoga postures, but also breathing, mindfulness, meditation, as well as cognitive behavior therapy are effective treatments. Is there anything else that you can recommend?
Yeah, and so you know what, your doctors may not even talk to you about these topics in routine conversation. So the most common brain-gut connection medication would be a medication, actually, and these would be antidepressants that your doctors may have talked to you about. Now, one of the medical treatment options for IBS are low-dose antidepressants. Common examples of these would be amitriptyline, for example, or nortriptyline, which we would use routinely. Now, these medications were discovered more than 70 years ago and were originally developed for the treatment of depression. But in fact, we found out that although people's depression symptoms improved somewhat, their IBS symptoms improved even more so. So we think that's the case because it's improving the connection between the brain and the gut. So antidepressants are treatments for IBS and probably the most commonly used medications to improve the brain-gut connectivity. But I would just say be cautious if that's the route you embark on, because antidepressants definitely can be effective. But if you haven't tried, and it's probably best to position these a bit later in the course. If you've tried all of these other brain gut strategies and have not improved, then it's very reasonable to go on an antidepressant. But these can be associated with weight gain. It can be associated with constipation, as well as multiple other side effects. So always just ask about the side effects before you go on to these medications.
Okay. And so are there medications then for the different types of IBS, or what form of treatment would you recommend for constipation versus diarrhea?
Okay, so one thing we didn't talk about was that there are 3 subtypes of IBS, and these subtypes are diarrhea predominant, where majority of your symptoms are diarrhea, constipation predominant, or IBS-C, whereby the majority of symptoms are constipation, and then there is a mixed pattern, and many of my patients will tell me they alternate. Some days they have constipation, some days they have diarrhea, and they don't really know why. So by far, IBS-C, or the constipation predominant, is much more common than the other 2 types. So the treatment of constipation predominant would be usually a healthy dose of psyllium-based fiber supplementation. And so psyllium fiber comes in all shapes and sizes and forms. And most people would be very familiar with the commercial product, Metamucil, as an example of that. But there are many others outside of Metamucil. So starting slow with a fiber supplement and increasing over time is definitely effective for constipation predominant IBS. But still, many of my patients don't necessarily, I mean, some of them respond nicely, but others don't. And in that circumstance, I would recommend an osmotic laxative. So an example of that would be Restorelax. But I would stay away from common ones that people use, which would be Senokot, for example. So optimizing Restorelax can also help with a good bowel regimen. But there's even a new kid on the block where the latest medication available is something called Constella. And some of you might be familiar with that one. And this one is very effective in terms of improving symptoms of IBS constipation predominant.
Okay. And then what about for diarrhea?
Well, that is definitely a trickier subtype to manage, I would say. Now, there is, and I saw this question very briefly in my chat box, and now it's disappeared, but there was a question around, or comment around SIBO, which is small intestinal bacterial overgrowth. Now, SIBO is a different condition compared with IBS, but it does have some basic overlap with IBS. And what's going on here with diarrhea predominant IBS is that the bacterial profile in your gut may be altered. We call this dysbiosis. So when you have disrupted that balance in your gut between the beneficial versus the non-beneficial bacteria, you run the risk of having overgrowth of bacteria in your bowel, and that can cause diarrhea. So treating the underlying dysbiosis, or the altered microbes in your bowel, with antibiotics is likely to have some benefit. Now, there are different types of antibiotics, and perhaps the safest and most effective for IBS would be something called rifaximin. But unfortunately, at least in Alberta, rifaximin is not covered under most drug coverage plans, and it costs about $300 a month. So it is expensive. And although the trial data from studies would support its effectiveness, I can't say that I have a terrible amount of success with my patients in using that medication. So still, I find that the low FODMAP diet is the most effective to improve the diarrhea predominant IBS.
Okay. And should people stay on a low FODMAP forever? So if they eliminate all of these foods and they feel better, should they just stay off of those foods, or what are some of the next steps?
Okay, so the low FODMAP diet was only ever implemented to be used for a short period of time. So the low FODMAP diet is indeed an elimination diet. So you have to think about the fact that you're eliminating potentially a lot of foods that could have beneficial value. So while your symptoms may improve, you might put yourself at a risk of deficiency of a number of different nutrients if you continue the low FODMAP diet indefinitely. So what we recommend typically is that you can try the low FODMAP diet rigorously for 6 weeks. And if you've not had any response or minimal response after the 6 weeks, you're probably not going to be a diet responder. We have to move on to other treatments. But let's say after the 6 weeks, you've done extremely well and 50 or 70 or 90% of your symptoms have improved, then at that point, we would strongly recommend reintroducing foods. And reintroduction often can be accompanied by anxiety for a lot of people because now they're feeling better and now there's concern about what would happen if they start to reintroduce foods. But I would say that's critical. And meeting with your dietitian to be able to help with that reintroduction process is really important.
Okay, thank you. Let's go to the next questions. I think we covered that bottom point there already. So this is a question that someone sent in is around reflux. So I have reflux, but not acid reflux. No acid, just reflux. If their bed is raised up, what can they do? What are the treatments for reflux?
Okay, so it sounds like this person does not have acid reflux, probably because it's improved with this medication, with the rabeprazole. So good sort of strategies or lifestyle strategies to improve other types of reflux would be to eat small meals through the day. Don't eat till the point that you're feeling full. Try and cap your food intake at 50% of your satiety levels. And then, but you'll have to eat multiple meals throughout the day likely. So small, frequent meals through the day, and try and minimize anything to eat or drink within 3 hours of bedtime. It takes on average 3 hours, maybe even 4 for some people, for their stomachs to empty completely. And the fact that one's having reflux indicates that there's probably still some food left behind in their stomach. So use the effect of gravity. So when you're upright, food passes through more effectively. So use the effect of gravity to help empty your stomach. So now, assuming you've tried all of that, and you're eating small meals, you're not feeling full, you're not eating before bed, but still you have reflux, then medications may be required. And there are medications to help empty food from your stomach and help improve the motility of your gut.
Okay. So now the next question, what can you do to reduce the inflammation and pain after a reaction? What's the safest way or safest food and the worst food to introduce to a hypersensitive stomach? How long should you wait to reintroduce foods after a severe attack? Then there's a question about some medication, rifaximin, and why does it just keep getting worse, even when I'm on less than 10% of the low FODMAP diet?
Okay, so there's a lot in this question, and I guess I'm going to make some inferences. I'm going to infer that this person has a diagnosis of IBS rather than inflammatory bowel disease, because my response would be different. So assuming that this individual does have IBS, and it sounds like maybe IBS-C, because they're asking about this rifaximin for this medication. So if this is the case, then fiber-containing foods would probably be the safest food to answer this question specifically. There's no such thing as, I would say, as a worst food to introduce to a hypersensitive stomach. A lot of this is dependent on your own individual circumstance. So this is where I would strongly encourage you to keep a food diary. And I have all of my patients do this for a period of 7 to 10 days after I see them in the clinic. And I'll have them keep a journal as to how their symptoms are and try and record what they've eaten in the hours to days in advance of that attack. And that way we can try and help identify a specific trigger food that might be a trigger food for you. And then I guess, how long should you wait to reintroduce foods after a severe attack? That is, I need more information to be able to properly answer that question. But assuming you have tried the low FODMAP diet completely and you're feeling better, then I would say you need to continue on the low FODMAP diet for at least 4 to 6 weeks, and then it's safe to reintroduce foods. But having a systematic approach to reintroduction is important.
Okay, and I see a hand raise. from Ian and Arlene Neal. I'm not sure if I'm saying your last name correctly. Do you have a question?
Yes. So I'm the person that had posted that question, and I'm eating like literally maybe 10 different foods in my diet. And my new GI at the Gut Motility Clinic has recommended the rifaximin, but I've read a lot of different reports that say that there really isn't much of a result from it. And so I'm hesitating to put that kind of money out for it. And like my last severe attack was foods that I've eaten before and had no problems. But then I have about 3 to 5 days of just severe stomach tension where everything just goes hard. And I'll go through the night with pain. I'll be woken up with pain. And anything that I eat will cause inflammation and almost make it feel like it's infected, like an infected wound. And that goes on for about 5 days.
That adds a lot of context. Thank you so much for sharing that. And I guess if I can just follow up with one more question, do you have regular bowel movements or do you tend to be constipated?
I do have IBS, and I'm on the Resotran, Constella, and Delphilax 5 milligrams every night. And that does keep me regular.
Right.
If I try to take out one even for a day, I might be okay the next day, but by the next day, I'm in trouble.
Right. Okay. So definitely you have more severe symptoms. I appreciate the question now. And then can I just ask, after you have a bowel movement, do you feel better?
Yes, like I typically empty out by around 10 or 11 in the morning. And then I always feel good, but it's like my body just can't wait to get rid of everything in the morning.
Okay. Yeah. So I'm with you in that I'm not confident the rifaximin is going to have a huge impact. And given the costs that we're dealing with, it's a bit of a risk-benefit ratio between the trial of the rifaximin and the cost of it. I don't know that I would necessarily think about rifaximin for you as the next step, but I do wonder whether you have the option to increase the doses of the existing therapies that you're on, the prucalopride, the Resotran that is, or the Constella.
So those all work every day. Like if I take them all, it's great. I empty right out and I feel relief and I feel like inflammation does go down for a short while until I eat a meal. And then throughout the day, it just builds up and builds up, and it doesn't matter what I eat, what I don't eat. As I say, I'm pretty much down to the same breakfast, lunch, and supper every day, and it's not a lot. So I do take a gluten-free, dairy-free, soy-free, sugar-free multivitamin every day, and that seems to be helping with my levels, as my blood work is always great. But that's the only thing that I can contribute my health to is my vitamins.
Okay. I'd be happy to chat with you offline,
Okay.
or help, or even, I might even recommend the LyfeMD application for you. I feel like there may be a lot more, or at least a few items more that we can try to help you help you feeling better. If you're open to that approach, I'd be happy to work with you through the LyfeMD app.
I do have the LyfeMD app, and I do work with Charlie and Chelsea. And so they've been helping me a little bit and trying to find different things, because even with a dietitian, if you can't eat anything, there's not much that they can do to help you. Protein is a huge problem for me, so I haven't found a protein drink that I can tolerate yet, because I had cancer last summer, and since then I've even become intolerant to rice. So even the rice protein drinks or the plant protein drinks I can't take.
Okay, so it may be actually that the diet may not be the right angle to support your symptoms, and that we may need, I mean, of course, we can continue to work with the diet, but I think if we can work with some of the other programs, and I have a few ideas around medications that we can also try. So maybe I will ask Charlie and Chelsea just to connect with me, and we can brainstorm some solutions for you through the app.
Thank you.
Yeah, thanks
You're
so
welcome.
much. Both, I think that's, it's so, every person is so different and has such a different story. So thanks for sharing that, Darlene. I'm sure there's some other people listening that can relate. So Dr. Raman, you did talk a little bit about LyfeMD, and we are both co-founders of LyfeMD. Could you talk a bit? We just have 4 minutes left, and I do want to provide everyone on the call today, if you do not have a code already for the LyfeMD app, London Drugs has graciously sponsored. Anyone who does not have a code, they will pay for you to have the LyfeMD app for 1 year at no cost to you at all. So I do want to just walk through people. If you do want to stay on the line, we might go a little past 5 to show you how to do that if you are interested. But Dr. Raman, can you share a bit with us what is LyfeMD? What is some of the evidence that supports? And we've got about 2 minutes.
Okay, so what we originally developed the LyfeMD application because we found that oftentimes there's not enough time in the clinic to discuss lifestyle therapies with your physician, whether that be the family physician or whether that be the gastroenterologist. So the LyfeMD app is used or was developed to fill the gaps in care, and these gaps include selecting optimal dietary programs, implementing yoga, breathing, and mindfulness programs, as well as the Retrain Your Brain program. So we have studied the IBS app in over 50 patients so far, and currently there are about 800 patients using the LyfeMD app for various different reasons. And the LyfeMD app has been shown to improve your sleep, improve your fatigue, improve the quality of dietary intake, as well as improve physical activity minutes, as well as the overall experience with physical activity, amongst other findings. So users that have used LyfeMD feel better on a number of different fronts. We now have a specific IBS study that's ongoing. And if any of you are interested to participate in that IBS study, you will get the benefit of having both the app as well as a coach. So I probably have taken up my 2 minutes, Lorian, so I'll turn it back to you.
Sure, thanks. Charlie, if you can go to the next slide, please. And I think we might have to skip some of the comments. This was, okay, one comment here around what somebody said, because this was very meaningful to me, as someone was talking about how after using the LyfeMD program, it gave them hope that they can get their lives back. And we've had many positive patient really testimonials and responses to people who've implemented and used the whole program, the whole solution, in terms of the diet, therapies, physical activity, yoga, breathing, mindfulness, as well as the Retrain Your Brain program. Charlie, I just want to go to the next slide, and the next one. So this is how you download the app. So you can actually use the app from your phone or your iPad or your computer. So if you go to the LyfeMD website, and it's LYFEMD, do the same thing in the App Store, or you're not gonna find us. And you can go to the login sign up button that you see on the screen there, or you can just install the app onto your phone. And next slide, please. And then to sign up, all you have to do is open or go to that login sign up page. You'll see that tiny little blue thing at the bottom there that says sign up now. You click on that. this sign up page will come up for you where you have to enter your email address. We need to know you're not a bot. So we have to send a verification code that you then enter into the app. Once we know you're not a robot, you can then enter your password, your name, and your subscription code. So now for everyone on this call, as I mentioned, London Drugs has said we will sponsor subscriptions for patients. Even probably some of the patients on this call have already been sponsored by London Drugs. And so that code is IBS 2023, and we are going to leave that open for 2 days. So if you or you know someone else who has IBS and they would like to try the LyfeMD program, you can use that code and you can get a subscription to the app at no cost to you at all. And that's all paid for by London Drugs. Next slide, please. So once you you fill in that information, you enter your subscription code, you can open the app, you log in with that email address you entered for the verification, and then also note the password that you filled in on the sign up page, because that's the password you will have to enter on this page. You can also click the Keep Me Signed In button, so the app isn't always exiting you every time you go into it, but you do have to click that Keep Me Signed In. And then if you do have any questions, if you are connected with the coaches, you can ask your coaches. If you do have LyfeMD and you do not have a coach, on the bottom right-hand screen, there's 2 little bubbles, get connected with our coach. When we look at we've done actually randomized controlled trials, which is the highest level of study you can do. And when we look at our data from that study on the LyfeMD program, the patients who've had that extra support from a coach or a dietitian have done very, very well in terms of their outcomes. So, and if you do have questions, you can, we have our phone number there on the screen. You can write that down, or you can also contact us by email at info@lyfemd.com. And again, just make sure it's LYFEMD. I just want to say thank you to everyone today for participating in this talk. Please follow up with your questions. Dr. Raman, thank you so much for this amazing information and support that you not only have done through really designing a program that patients can use easily like LyfeMD, but your time and the information that you provided today was so great. So just thanks for that. And thanks everyone for participating. We are so glad to have you here. And please, any other questions that you have, just email us and we will get back to you. So after that, I'll say goodbye to everyone and thanks so much. Have a great rest of your evening.
Okay. Okay.
Hi, could I get that code again for the Life app?
Sure, it's IBS 2023.
IBS.
Yes,
IBS 2023?
yes.
Excellent.
IBS for
Thank you very
irritable
much.
bowel syndrome 2023. Yes, and you have this.
Okay.
This is good till the 20th of April midnight,
Okay.
and you get a 1-year subscription with this.
Fantastic. Thank you so much.
No problem. May I quickly ask you where you heard the talk? Where did you hear us about the talk from?
From LyfeMD app. It was sent in my email, but I want a friend of mine to get the app because she's just been recently diagnosed.
Oh, I see. Okay, well, do sign up, and we'd love to see how you can benefit from the program.
Excellent. Thank you very much.
Thanks for joining.
Bye-bye.
Yep. Bye.
Yeah, bye.
Okay. Hi, Dorian. Have feedback. We love. I need to hang you. Everyone left. They said I need to leave. But I tried to. How do we? Doesn't matter. This is still over there, honey. I need to hang you up. Okay, and to this. She said the only one left, me.
Well, it's like you keep joining.
Yeah. I need to be out. I need to hang you up. I'm the only one in the room.
Well, you're the only one there. There's nobody else there. What you should do, shut your phone off. Like right here.
Okay.
Is that what that beeping means?
Well, you heard the message. I'm the only one there.
Yeah, well, that's because you keep clicking on here to join.
Oh. What? Oh, well. Cannot do anything. Just shut off.